Welcome to Deep Dive Dialogue. Our topic for discussion today is transforming breast cancer care through precision oncology. By studying each patient's unique genetic makeup and cancer type, precision oncology helps doctors choose the best treatment, reduce side effects, and provide more effective targeted care for individuals battling breast cancer. To discuss this topic, we are joined today by Dr. Jayanti Thumsi, who will share insights on how precision oncology is transforming breast cancer care. Dr. Jayanti is an experienced senior consultant at Apollo Hospital, Bangalore. She specializes in breast oncology with extensive expertise in healthcare management, patient safety, and healthcare IT. With an MBBS and MS from Grants Medical College, Mumbai, Dr. Jayanti leads as a breast oncology surgeon, delivering advanced care and exceptional outcomes. Welcome, Dr. Jayanti.
Thank you very much for having me. And I think it's a very wonderful topic that you've chosen. Thanks a lot.
Yeah. So, to begin with, could you tell me that how do breast cancer treatments such as surgery, chemotherapy, radiation differ from precision oncology in terms of approach and effectiveness?
Right. So, there is breast cancer is a heterogeneous disease. That means it is not just one type. There are many, many subtypes within the broad classification, which is called breast cancer. So, obviously, there is no one treatment which will fit all the patients, right? Yes, broadly, we can classify as surgery, chemotherapy, radiation therapy, hormone therapy. We have targeted therapy, immunotherapy. There are many, many therapies which have come up now. And in our experience, when we treat, say, comparing, say, two patients we have, everything is matched, their age or the type of the disease, the stage of the disease, everything is matched. We also do the similar surgery, we do the similar chemotherapy and radiation therapy. Yet, many times, the response that the patient responds to the treatment can be different.
Mhm.
Some patients, in spite of advanced disease, can do very well, and some patients who we think they have very early disease, they can relapse. So obviously, there is something more than what we were actually doing in earlier days. The way and the differences at the molecular level or the genomic level. And better understanding a need is the need so that we can precisely treat the patient. So when we broadly treat a patient, many of them do well, but some of them still relapse, and we were stuck earlier days. But now there are answers to many questions which were unanswered few years ago.
That's right. And that's what I also believe that biomarkers, genomics, they are playing a big role. And so my
Yes.
next question is around this only, that how has the use of biomarkers and genetic profiling transformed the way oncologists personalize treatment plans for breast cancer patients, especially?
Right. Now, first of all, to talk about, say, we do immunohistochemistry markers like estrogen receptor, PR, that is progesterone receptor, HER2 receptor. These help us in planning the type of chemotherapy. Now, for example, the patients who are HER2 positive, there are certain targeted therapies available. There are monoclonal antibodies available, which precisely act on these cells which show the receptors. So that means it is a targeted therapy, and the remaining cells are spared from this kind of the therapy. So the what happens is, in this also there are so many drugs which have come out. There is trastuzumab, now there is pertuzumab, there is TDM and lapatinib. There are many, many drugs which have come up which help in precisely treating only those targeted cells. Also, hormone therapy like ER, PR, and there are therapeutic implications in there. So we can give certain kind of hormone therapy. Now, even in hormone therapy, there was just tamoxifen or there was aromatase inhibitors earlier. Now we have CDK inhibitors. There are many more treatment options which are available, wherein the idea is to make the treatment more tolerable, to decrease the side effects, to make the treatment more effective and to give good quality of life, So, with so much advancement in breast cancer treatment, we see that the 5-year survival rate is highest in breast cancer. So when we treat a patient, we're not treating only the cancer. We need to understand that since the longevity is going to be there, we need to precisely plan so that we also give a good quality of life to the patient. Otherwise, we've treated the disease and the quality of life is not there. Still that doesn't serve the purpose, and that is where these biomarkers come into picture. Right now, talking about the genomic, the genetics, we have patients who have a strong family history, or sometimes very young age, a patient develops breast cancer, and we don't know why is it that at such a young age somebody has developed the cancer. In such patients, we do the genetic profiling, we do the germline mutation, what we call, is there any hereditary mutated gene in them, the BRCA testing, or there are many more other genes also. So doing this testing, it helps us. First of all, if the patient has already developed cancer and we do these testing in them, they have therapeutic implications. We would probably add a platin in carboplatin when we're giving chemotherapy, or after the completion of treatment, we may add PARP inhibitors. So, and the type of surgery that we may do would also probably differ. We would probably do a mastectomy and not a conservation surgery in such kind of patients. And also a woman who has not yet developed cancer but has a family history, and if she's worried, what is my risk? Even in them, there are a lot of risk reduction, chemo prevention, what we call, or risk reduction surgeries that we do, prophylactic surgeries that we do, or we at least, the patient becomes wiser as to what to expect, and also the doctors what to expect and what is exactly that we are looking for, so as to reduce the risk of the disease or at least detect it early. So we do a better surveillance. We call them more often. Maybe we'll also do breast MRI in these cases. So there is a lot of implication and in understanding the genetic profiling of the patient. And a lot of patients ask, oh, what if I get to know, I fear, how will it add value? It will only increase my stress. But I really believe that knowledge adds power, and it better equips us to deal with these kind of patients.
Right, right. And as we have got to that precision oncology is improving the patient care and quality of life, and also we have the risk reduction surgeries. What do you think that there are potential barrier to widespread adoption of all these in breast cancer care?
Yeah, I feel that yes, in bigger places like bigger cities, it is used and it is a new norm. It is routinely used. But in smaller centers, say tier 2, still the acceptability is not there. Also, it has cost implications, and adaptability also may not be there. So, and also so much research happens. We need to keep ourselves updated. And I've seen that in bigger hospitals. Like I work in Apollo Hospital, it's a norm. We use it routinely. But the acceptance or adaptability, cost is also a factor, which could be detrimental. Now, in say in a government setup or in tier 2 cities, I think that could be one of the barriers.
Right. And since you are practicing, can you share some examples of successful cases where precision oncology has outperformed conventional therapies in breast cancer management?
Oh, certainly. We have had, say, elderly women. I'm just giving you a few examples. She was about 78 years old and not a very fit lady. She had cardiac issues and many issues. She came with a large lump in the breast, and when we did all the necessary investigations, she was ER/PR strongly positive, HER2 negative. So traditionally we would have given only hormone therapy, but now we have CDK inhibitors. and we gave that, and the lump has completely vanished, you know.
Mhm.
So she was not fit to undergo any kind of surgery or any kind of chemotherapy, and these drugs are very tolerable, you know. They, in the space at home, they can just take these oral medications, and she's doing extremely well, and it really seems magical, you know, how they did it, you know. Another example I would like to give, we had a family where we had treated the mother for breast cancer. And when she was young, she was about premenopausal, you know, when we treated her for breast cancer, and we did the BRCA testing for her. She was detected to have BRCA1 positive. And then she had two daughters. She has two daughters, and one of the daughter was just married, you know. And then they were worried whether what happens to my daughters, and we said, of course, you should do the BRCA testing. And we did the BRCA testing. One of the daughters it does not have any inherited gene, but the other daughter, who was just married, had a BRCA positive in her as well. So we advised her to quickly complete the family, so that we can do the risk reduction surgery, and we have done the risk reduction surgery. So timely action has been done before the cancer developed in that kind of a family, you know. Also, there was another patient who was BRCA positive, and she had an advanced disease, but after the treatment, we have given her PARP inhibitors, and in spite of advanced disease, she's doing extremely well, you know. So there are many such examples that I can keep on giving, you know. And immunotherapy now, you know, which we give for triple negative breast cancer, that is again a phenomenal treatment, and we have seen a wonderful effects, you know. Otherwise, triple negative was kind of a blind spot. We were treating them just arbitrarily. There was no targeted therapy available. But with immunotherapy, and yes, we see wonderful results in these drugs. Of course, cost is a big inhibitor in all of these.
Yeah, you have given very good case-based studies, and I believe that precision oncology is really making some difference. So, can you give us some ideas that how it can be made accessible and affordable to larger population so that breast cancer can be addressed more effectively?
So I'm sure that see, when we started practice, okay, trastuzumab was given for HER2 positive patients, and trastuzumab was extremely expensive. Each injection would cost 1.25 lakhs, 1.5 lakhs, and we would have to give 17 of those. So you can imagine the cost. And over a period of time, the cost came down when more and more companies come up with these drugs. And you know, to begin with, yes, the cost is high, but given a period of time, it will become affordable, and it will be accessible to more number of patients. But I also hope that this is also applied in the government setup. You know, we work in a corporate hospital. The kind of patients who come to us are different. They're very affordable, uh, but very sadly, in our country, it is affordability which often defines what would be the outcome of the treatment, because it is not accessible to all. But these are certain government policies which need to be changed, so that every person has a right for the best treatment which is available in our society. That is what I really think.
Yeah, with that note, thank you so much, Dr. Jayanti, for sharing these valuable insights of the transformative approaches which are coming up. And we hope today's discussion inspires continued progress to fight against breast cancer. Thank you so much.
Thank you very much. Thank you.